All right. Hello, abnormal students. How's everybody doing? It's good to see everyone. Okay. Plan for today is to cover sexual dysfunction. And I'm going to start out with this lecture, and I'm just going to ask everybody in here, are we all adults? We're adults? Okay. So I'm going to treat this lecture as that. Okay, so sexual dysfunction. So keep in mind, last week we covered the sexual paraphilias, and the paraphilias were when people are doing abnormal kind of stuff for sexual gratification. The sexual dysfunctions, on the other hand, these are going to be like ordinary people where there are some kinds of problems in their sexual functioning. So let me go ahead and get the PowerPoint started here. And I want to give you some background on where we got a lot of this knowledge. So between Kinsey and Masters and Johnson, let me kind of tell you their story. So Kinsey was the first researcher to study sex by doing surveys, anonymous surveys for individuals, and just asking them questions. And like we saw last week when we talked about how sexual orientation once upon a time was, if anybody was not heterosexual, the DSM considered that to be abnormal. And part of the reason why that got removed from the DSM is that Kinsey did his survey research and found that so many individuals have had bisexual experience. And so it really is not the kind of thing that was necessarily deviant. So Kinsey was the survey guy. And then I want to tell you about Masters and Johnson. And then I would also like to recommend they're on Netflix, this show called Masters of Sex. And it's actually a really good show. To give you a little background on Masters and Johnson. So Masters was a physician, and he studied sexual activity by watching people either masturbate or by watching people engage in sexual activity in his lab. He had difficulty at first recruiting participants into his research, and Johnson was his lab assistant when he was married to another woman, and she was very socially skilled and very good at recruiting people into the lab to wire them up and watch them have sex and record the physiological information. Now, they ended up having an affair, and so he ended up divorcing his wife because Masters and Johnson had this affair together. And then keep in mind that their marriage did not, they had an affair, they got married, their marriage did not last. And so the take home to that is that sex is not everything in a relationship necessarily. Okay, so any questions? These were real people. Kinsey was a survey guy. Masters and Johnson actually would observe individuals engaging in sexual activity, and they were able to really kind of move the science forward in understanding how sexual activity works for people. Okay. Now, what I want to first go over here is what is considered to be a normal sexual response cycle. And I want to talk a little bit about how the nervous system is going to interact here. So for individuals to experience some desire for sexual activity, and this would, for a lot of individuals, would be considered like a fantasy phase, like they're thinking about it. And in this stage here, the fantasy or the desire stage, the parasympathetic branch, which remember is the rest and digest branch of the autonomic nervous system, the parasympathetic branch has to be dominating for that desire phase. Then there becomes sexual excitement. So for men, that would be an erection of their penis. For women, that would be an erection of their clitoris. There would be swelling and lubrication happening in the vulva and the vagina for women in the sexual excitement stage. In order for an individual to reach orgasm, the sympathetic nervous system, which remember was that kind of fight or flight, the sympathetic nervous system has to kick in. And that is why, and again, Masters and Johnson studied this. So they would have individuals wired, they'd be collecting their blood pressure, their heart rate, the respiration rate. But that is why at the stage of orgasm, there's very high heart rate. There tends to be abnormality in breathing, the way individuals breathe. And So that would be the sympathetic nervous system would have to kick in. And then there is either a resolution phase, which for men is automatic. There's a refractory period. Men immediately go into resolution, and a refractory period for, a good 15 minutes or something like that. If they are able to, if they want to continue with sexual activity, they've got to take a break here in the resolution stage. Women, on the other hand, have the capability, and this makes a lot of sense across evolution, the reinforcement value for women. Women are able to go and experience orgasm and then loop back around, continue to be sexually excited, and have additional orgasms or multiple orgasms. It's like girl power. Okay, but what I want you to attend to, because this is going to come back up as we go through the different sexual dysfunctions, you're going to kind of even see the DSM has the dysfunctions in the different stages. But I want you to know there's an intricate interplay between parasympathetic has to be dominant for fantasy, desire, arousal, excitement, but sympathetic has to kick in order for an individual to reach orgasm. And then at resolution, that is back to parasympathetic being dominant, which is why a lot of individuals find sexual activity to be very relaxing, or a lot of individuals like to sleep after sexual activity, because the parasympathetic, that rest and digest, kicks back in. Okay. Now I want to survey you. I'm going to stop the share. And I want to go to the next slide, and I want to survey you all here. And let me go to my poll. Okay, I'm curious. Let me go ahead and launch the poll. Have you all, in your knowledge and your, how you've been educated in your personal experience and your knowledge, have you ever heard about the sexual response cycle put in this way? And with the nervous system, the parasympathetic and the sympathetic kicking in. So I'm curious of how many of you have heard this. Okay, the majority of you, I'll share the results. The majority, 85%, are saying no. About 15% of you have heard about sex in this regards. So let me go back and share the screen again. Okay. I remember when I was younger and I first learned about sexual intercourse, and I remember thinking, that is really disgusting. That is really gross that people would do that. And again, I was a kid, okay? And I want to tell you about my story with Christian. My son was I think he was about 5 years old at the time, and he knew about birds and bees. He had asked, and I always had this, like, if they ask, I just answer. So he knew about it. But there was one day I'm driving him home. He's in his car seat back behind me. And he said, "Mom, how little was I when I was born?" And my response to him was, "Well, you were 6 pounds on the dollar." And then he's back there and I can see he's thinking, he goes, but how small was I when I started? And I was like, "You mean like when you were first made?" And he was like, "Yeah." "Was I 6 pounds?" And I was like, "No, you were just teeny tiny. You were a little zygote." And he's like, "What's a zygote?" I said, "You remember, we've talked about this, sperm, daddy had the sperm, mom had the egg, and the egg and the sperm got together and they made the zygote. And then your cells just kept replicating. And then you became a baby and you were born at 6 pounds. He's back there and he's thinking, so tell me again how the sperm and the egg got together. So I explained to him sexual intercourse, and he's back there. I'm watching him in the rearview mirror as I'm driving and I'm talking to him, and he's making this face and he's like, "So you and daddy did this?" And he's thinking twice, right? For him and his brother. And I was like, "Yeah." And he makes this face and he goes, "Were you laughing when it happened?" It was just one of those, like, to a little kid, it just sounds so preposterous, doesn't it? It sounds either gross or like, why on earth, like, did you bump into each other in the hallway? Like, how on earth does that happen? Because it's just kind of hard for kids to comprehend. Okay, let me get my screen here. So you're going to see that the way the DSM organizes these is kind of according to those stages in that normal sexual response cycle. So we're going to start first with male hypoactive, meaning below normal activity, sexual desire disorder. Okay, so below normal desire, and this is for men. And you're going to see this throughout in the DSM. So we'll kind of get this in your notes and then just kind of know that this is going to be applicable for all of these disorders. Here we have persistently or recurrent deficient. Deficient would be low level. Absent would be 0. Sexual or erotic thoughts or fantasies or desire for sexual activity. And so this would be either low desire for men or 0 desire for men. And keep in mind, the DSM reminds us, and this is a good thing, we've got to be careful. We've got to consider a person's age. So this would be an unusual diagnosis, say, for a young man who's 20 years old. This would be pretty common for, say, a man who's 90 years old. We've got to take into account their health. And we know that individuals with chronic disease tend to have more issues with sexual dysfunction than individuals who are fit and healthy. And then they say we've got to keep in mind their partner. And if there is a partner, what compatibility is there? So as an example, if we had a heterosexual couple here and the woman wanted sex every day or twice a day, and the man did not want sex every day or twice a day, we would not put this label of hypoactive sexual desire disorder on him, okay? Because based on typical data, a woman wanting once a day or twice a day is kind of abnormal. It's kind of unusual, okay? So you always take into account, if there is a partner, what's the compatibility with the partner. Then they say for all of these dysfunctions, they've got to create either distress or interpersonal difficulty, and it has to be ongoing 6+ months. And the reason for that is everybody on occasion has some sexual dysfunction. And one of the things that we do in treatment is actually kind of normalize that, because for a lot of individuals, they could have an episode of some kind of sexual dysfunction. And if it's so upsetting to them or so shaming to them, that's going to create more anxiety and more dysfunction. Okay, so sort of knowing that this stuff is kind of normal for individuals. So, but this has got to be going on for a long time, at least a half a year. Okay. And it's either distressing to the individual who has this, or it's creating issues in the couple. And then they say down here in C, whoops, let me go back, that we want to take into account if there's another axis 1 disorder that explains this. So let me give you a common example. A lot of times individuals who are clinically depressed lose their sex drive. Okay, they lose their, and keep in mind, Freud called that libido. So sex drive, libido. So if the diagnosis is depression, depression's going to trump this diagnosis. Okay, because this would just be a symptom in the depression. They also suggest that we pay attention to what substances people are consuming, because a lot of recreational substances or even prescription medications are going to create some sexual dysfunction. A real common one nowadays is people who are taking SSRI antidepressants. And they also warn us, if there's a medical condition that can explain this, like let's say a person has uncontrolled type 2 diabetes, then the diabetes would trump this as a psychological disorder diagnosis. Okay. Any questions here? Okay, so that was the male counterpart. Now we've got the female counterpart here. And they call this female sexual interest or arousal disorder. So here for the female, they've got this clustered together. They've got the desire phase, and then they've got the excitement or the arousal phase put together. And this would be for women that there'd be a lack of or significantly reduced sexual interest or arousal for at least 3 months. But normally this is going on for longer than that. And it's just like it sounds. There's either absent or reduced interest in sexual activity. There's either an absence of or reduced sexual or erotic thoughts or fantasies. There's either total absence or reduced initiation of sexual activity, or so this person is not initiating. And then if their partner is initiating, they're usually saying no, they're unreceptive to their partner. And then they go further into the excitement phase. Either there's absence or reduced excitement or pleasure in the majority of sexual encounters. No interest in any type of internal, external cues. So no interest in any kind of thing visual or in writing. A couple of years ago, I don't know if it's still circulating. I didn't read it, but I know I had friends who were into 50 Shades of Grey, would be somebody who would be seeking out that kind of erotic stuff in a book, as an example. And then if there is any type of touch or activity, there tends to be poor genital or non-genital sensations in the majority of encounters. So it's just kind of like what it sounds like. So there's reduced interest and problems with arousal for women, and it's either causing distress or it's causing interpersonal difficulty with their partner. Any questions? Okay. Now, sexual aversion disorder, now we're getting more extreme. And one of the things that I think you're going to see here is now we're getting more intense anxiety and intense avoidance here. So sexual aversion is something that you strongly dislike and avoid. So here we've got persistent, recurrent, extreme aversion to, or avoidance of all or almost all genital contact with a sexual partner. And this could be all contact, any kind of touch, but at times sexual aversion is for a specific act. So let's say we've got an individual who feels very comfortable, say, with sexual intercourse, but has an aversion to oral contact, either giving or receiving oral sex. So for some individuals, you've got like, certain things are okay, certain things are absolutely not okay. I can tell you in the situations where I've worked with individuals where it has to do with certain acts, a lot of time there is a sexual assault or a child sexual abuse type of background. And that's a theme we've seen we've seen that all semester, but certainly you're going to see childhood sexual abuse or sexual assault in teen or adulthood as being something that drives quite a few of these disorders. Okay. And then they remind us distress and interpersonal difficulty. In this situation, the sexual aversion and the avoidance feels comfortable for the person who has this. It usually ends up creating interpersonal difficulty with the partner, though, who would like to have sexual contact that this individual is avoiding. Okay, so this is more extreme than what we saw on the previous disorders. Okay. Male erectile disorder is just like that sounds. And keep in mind, this is symptoms. So it doesn't stand for sex, it's symptoms. So one or more symptoms experienced the majority of occasions of sexual activity. And then it's got to be going on for at least 6 months. And again, women and men, there are always going to be times, it is a normal type of thing where they are going to experience some transient sexual dysfunction. And again, if we kind of acknowledge like, yeah, that stuff happens, maybe it happens because there was alcohol consumption, maybe it happens because you're just exhausted. Those things happen. So this has to be going on for quite a while for it to be diagnosable. And in this situation, it's just like it sounds, marked difficulty either obtaining an erection or difficulty maintaining an erection until the completion of sexual activity, or a significant decrease in erectile rigidity. So not getting as hard as once was capable of. It's going to create distress and interpersonal difficulty. And then again, they remind us if there's a medical condition here or substance use or another axis 1 disorder that would trump this diagnosis. Do know though, that once there were medications put on the market like Viagra and Cialis, the Cialis commercials crack me up, especially the ones in the 2 bathtubs. It's like, I don't understand. Like, of course, there's not going to be sexual activity if you're in separate bathtubs. Somebody's got to get brave enough to climb in somebody else's bathtub. It's just like, oh, those commercials. And then the one where they've got all the subliminal Freudian message where he's throwing the football through the tire swing. Like, oh, yeah, that's not, subliminal message there. Anyways. Once those medications hit the market, a lot of men who were having erectile dysfunction, who would normally avoid seeing their medical doctors, would go to see their medical doctors because they wanted to ask for one of these erectile dysfunction medications like Viagra. And I can tell you that primary care doctors know, and this is important to know, that one of the best predictors of particularly middle-aged men starting to have erectile dysfunction is that's early cardiovascular disease. Okay. And so nowadays physicians, they're glad to get these guys coming into their office because they need a medical checkup if they've been avoiding a medical checkup, but they don't just hand out the prescriptions for Viagra or Cialis or whatnot anymore. They will, at that point in time, want to do a full cardiovascular workup. Does that make some sense that this would be? And when I think about cardiovascular disease and I think about blood flow, for both men and for women, there is normally very little blood flow in the genital area. And so, that tissue can live with very poor blood flow. But during sexual arousal, there's a tremendous amount of blood flow that goes into the genital areas for both men and women. So we're thinking about blood vessels that are normally almost like kind of non-existent, kind of collapsed. And then you're expecting them to be able to hold huge volume of blood. It makes a lot of sense that we would start to see cardiovascular disease evidence itself in something like this. Does that make some sense on a physical level? Okay. Now, technically, male erectile disorder is a psychological disorder. But when I think about all of these sexual dysfunctions, it's all totally mind and body. Okay. Okay. This used to be called, a lot of people use the lay term impotence. Okay. We don't call it that anymore because it makes it sound like the poor guy can't do anything in life. And that's not fair just because he's having some sexual dysfunction. This is a word that kind of connects to more than that. Questions here? Okay. Okay. So that was the male counterpart. Now we've got the female counterpart, female orgasmic disorder. And this is when there's a presence of symptoms either experienced, and again, so they do the 75 to 100%, meaning the majority of occasions of sexual activity. And there is a significant delay in or infrequency or total absence of orgasm, or a reduced intensity of orgasmic sensations. Now, I can tell you from the Kinsey research and the Masters and Johnson research, and then research on sexual functioning since them, that there is, and this has been my experience in working with women and friends and whatnot, there is a tremendous amount of variability in female sexual functioning as it pertains to the ability to reach orgasm. Okay. And so when we survey women, there are a lot of women who will say they absolutely never have orgasms. There are women who say that they always have orgasms during sexual activity. And then a lot of women say, well, it's kind of hit or miss. Okay. Sometimes when you ask men about sexual activity, the majority of men, like 99%, are saying that they are either masturbating or have a sexual partner and are reaching orgasm on a regular basis. There's very little variability in male ability to reach orgasm, but a lot of variability and differences in women. Okay. Again, it's got to create that distress or interpersonal difficulty. And let me back out of this. I want to play. This is just for fun. Okay, let me go over to my YouTube. For those of you who are Friends fans, Okay, and let me. Can y'all see the YouTube? Okay.
So, did you do it?
Yes, we had the sex.
Uh-oh. It was bad?
It was fine, you know, but she didn't agree with me as strongly as she agreed with Joe. She was more like, oh, I see your point. I'm aligned with it.
It was the first time, you know, there's not always a lot of agreement the first time. Yeah, not for girls anyway. Guys agree like that.
Look, you have to help me, okay? I mean, I know what to do with a woman. You know, I know where everything goes. It's always nice. But I need to know what makes it go from nice to, my God, somebody's killing her in there.
All right, I'm going to show you something a lot of guys don't know. Ready, give me that pad, please. All right. Now.
Well, you don't have to draw an actual, whoa, she's hot.
Everybody knows the basic erogenous zones. You got 1, 2, 3, 4, 5, 6, and 7.
There's 7.
Let me see that. Oh, yeah.
That's one?
Kind of an important one.
Oh, you know what? I was looking at it upside down.
Well, you know, sometimes that helps. Okay, now most guys will hit 1, 2, 3, and then go to 7 and set up camp.
That's bad?
Well, if you go to Disneyland, you don't spend the whole day on the Matterhorn.
Well, you might if we're anything like 7.
All right, the important thing is to take your time. You want to hit them all, and you want to mix them up. You got to keep them on their toes. Oh, toes! Yeah, for some people. All right. You could start out with a little 1, a 2, a 1, 2, 3, a 3, a 5, a 4, a 3, 2, 2, a 2, 4, 6, 2, 4, 6, 4, 2, 2, 4, 7, 5, 7, 6, 7, 7, 7, 7, 7, 7, 7, 7, 7. There you are. Yeah, that'll work.
Okay, that was just for fun. Okay. All right. Oh, let me back out of this. I've got another survey. Let's do females first in the polling. Why is it not giving me the option? Stop sharing. Here we go. Okay. So ladies in here. So let's talk about frequency for women during sexual activity and see what we get here. Okay, and here's what the distribution is. So we have 10% saying always, 30% saying sometimes, 10% saying never, and then we have some individuals who have not been sexually active. Let's survey men, and I will launch this. So same thing for men in terms of frequency. We don't have many respondents here, but okay. You get a slightly different pattern. And again, we've got, you know, I don't know how random the sampling is and representation is in this class, but 67% of men are saying always and 33% are saying sometimes. Okay. So we get that kind of classic pattern even with men in this class. Okay. Okay, some other issues for women. There are quite a few women that report experiencing pain during vaginal intercourse, and 70% of women report that they experience pain if they're engaging in anal sex. And so word out to all of you women in here, you want to make sure that before engaging in any kind of intercourse that you are well warmed up and lubricated. And if you are experiencing pain, I think it's important to communicate that to a partner, because any type of experience of pain is going to make that individual anxious during any future sexual activity. And anxiety is going to breed, remember anxiety, if you kick in sympathetic nervous system at a time when you are trying to get aroused and you want parasympathetic nervous system to be in control, kicking in that anxiety response is going to undo that ability to become sexually aroused. And so that's a pattern that a lot of individuals get in too. We also get this really interesting kind of thing where, and a lot of this has to do with culturally how women are raised in our society, raised to please others, but particularly to please men. And so, and there was a survey done back in 2004 called the American Sex Survey, and it surveyed women and asked them if they fake orgasm. So they just pretend to have an orgasm, but they're not really, their body is not really responding. They are not necessarily having that climax. What are the reasons why they do that? 26, so the majority of women who do fake, and I, as an advocate for everybody's sex life, I encourage people not to do this. That honest communication is probably a better way to go, but it makes sense that a lot of women are doing this. The majority is to please their partner, to have their partner feel like they have been sexually satisfied, even though they were not. 22% say that they fake it to hurry up, get it done. 10% say, if this is kind of the inverse of please the partner, 10% they don't want to hurt their partner's feelings. 9% saying they were tired. 7% saying it wasn't going to be satisfying, so let's end it. 3% boredom, 2% not in the mood, 2% too young and inexperienced. I'm curious, is this surprising to anybody? Okay, I see some heads nodding. Okay. One of the things I think is really interesting, that women usually on a regular basis go and see their gynecologist for their female care. And gynecologists tend to be very good at screening for sexually transmitted infections. And they're really good at helping women when they desire some type of contraception or birth control, helping them with birth control. It is highly unusual, though, in the gynecologist world to ask women, first of all, about history of sexual assault. And men should be screened for that too, because men do get sexually assaulted. Or to screen women for sexual dysfunction. So it's really interesting how medicalized those types of visits tend to be without looking at this kind of stuff that creates more problems oftentimes for individuals with sexual dysfunction. So it tends to be very medical and not necessarily this mind-body stuff that could be going on for individuals. Okay, next disorder, this is for the guys. Premature or early ejaculation. And so this is persistent recurrent pattern of ejaculation during partnered sexual activity within about a minute following penetration and before the individual wishes it. The DSMs become more humane in number 5 here than in number 4, because it used to say before the partner wished it. And we don't know how demanding that partner could have been. So now it's happening very quickly or before the man wishes for it to occur. And keep in mind, again, this is going to be a normal occasion for guys, depending on different situations. If it's been a long time since their last episode of sexual activity, you're more likely to see this happen. This oftentimes will happen with a new partner early on in a sexual relationship, which is unfortunate when they're trying to impress a partner. And again, for this to be really diagnosable, true premature ejaculation as a diagnosis, it's got to be going on for a long time on the majority of sexual occasions. Some of the other definitions, again, before the partner desires it, but up here I like the idea this should really be about the individual, the man here, or an inability to control it. Okay. With experience, this tends to, for guys, happen less often. And a lot of times guys will talk about learning with a partner how to go in and out of their level of fantasy when they're having sex. So do some math problems, think about baseball a little bit, kind of go elsewhere to be able to last longer. That type of thing, that where experience pays off for gals, experience pays off for guys. Okay, questions? Okay. Male delayed ejaculation, so the opposite problem here. So this would be presence of symptoms on the majority of occasions of sexual activity, half a year or longer, where the individual doesn't try to delay. He's not trying to delay, but he absolutely is struggling to be able to reach orgasm and ejaculate. And there tends to be infrequency or absence, total absence or infrequency of the ability to reach orgasm and ejaculate. And so this can be happening after excitement and an erection, but then there's an inability to be able to finish. And again, they remind us down here at the bottom, we want to check for medical conditions. One example, I talked about the SSRI antidepressants interfering with sexual dysfunction. I've seen more in women who have side effects from antidepressants will have no sexual desire or really struggle to reach orgasm. I have worked with some guys who are on SSRIs who say it helps them last longer and they appreciate the side effect. But then I've worked with some guys before who've been on SSRIs and they say that they can get aroused, but they can't ejaculate, they can't reach orgasm. So the antidepressants are kind of, for a lot of individuals, are creating some side effects in the bedroom. Okay. We got a new name for this. This used to be straight up called vaginismus, and now it's called genitopelvic pain penetration disorder. So this is for women. And formerly known as vaginismus is when there is, upon attempt at penetration, this is the vagina here, where it spasms, not a pleasant orgasmic kind of spasm, where it spasms shut and absolutely prevents penetration of a penis or a finger into the vagina. And dyspareunia means pain. And I want to back up for a second here. Here we're talking about a mind-body psychological phenomenon, but I want us to back up, and who can tell me when in the real world, when women are experiencing pain in the genitals, what is the number one reason for that pain? It's the same thing for men who are experiencing pain during sexual activity. Can anybody throw out a guess? We've mentioned it already today a bit. Sexually transmitted infections. Okay, so I want you to know, like in the real world, the number one reason why individuals will have pain is because they have some type of sexually transmitted infection. Okay. technically for this diagnosis, there is no physical abnormalities and there is no sexually transmitted infection. So they're experiencing pain usually because either they have the vaginismus and it's spasming shut, or they're experiencing pain because they're just not well aroused. For women, men get that blood flow and they get that erection. They can get that pretty quickly. For women, it takes a while in the additional blood flow to push out moisture inside the vagina, which is why it takes women longer to warm up. Okay. Just on a physical kind of level. And so a lot of times women are experiencing this dyspareunia and this pain because they're just not adequately aroused and lubricated. Okay. So problems with vaginal penetration, vulvovaginal. So this would be the exterior of the genitals for women, pain on the outside as well as on the inside. And this makes a lot of sense to me. And this is going to have implications for how we think about treating these sexual dysfunctions. If there has, over time, if there has been pain, there's going to be fear and anxiety, even in anticipation during or resulting from penetration. Okay. So if you're scared, you're more likely to not be adequately aroused because sympathetic nervous system has kicked in. And because of that, on a physiological level, there is going to be poor lubrication and likely more pain. So can you see how this gets cyclical is what I'm getting at for a lot of individuals. Yeah. If it's hurt before and there's fear that it's going to hurt again, it probably is going to hurt again because that anxiety is preventing normal arousal. There, again, for this would be more the vaginismus, would be that tensing or tightening of the pelvic floor. And for both the gals and the guys in here, this is not a good kind of tightening. Okay. It's not like a spasm, like orgasm feels pleasurable for women. It is more of a tensing and a tightening that is unpleasant. Okay. So any questions there? Okay. So let's talk a little bit and keep in mind that this would be for any kind of sexual activity for couples. And so these could be couples who are heterosexual, could be couples who are gay. And what happens for a lot of couples is that early on in the sexual relationship, if there is the typical dating and the typical script, so I'm not talking about hooking up culture here. Typically what couples end up doing is walking through the so-called script. And the so-called script would be things like holding hands, kissing, then touching, and then eventually oral or regular intercourse. Okay, so rounding the bases kind of thing. And typically in those dating relationships, again, this is an enduring relationship, not a hookup, there tends to be lots of time with foreplay early on in the sexual relationship, which is beneficial to both individuals in that couple. But over time, what happens for a lot of couples is they get into a pattern where they're trying to be almost efficient with the sexual activity. So there's less foreplay. There's more of like, it's late, we got to get to sleep, we got to get up early tomorrow, or if we've got kids, you know, that type of thing. It's like, let's get this done, let's have some fun and go to sleep because we're both tired and we need a good night's sleep. As that happens, as that moves from that really passionate with lots of foreplay to this kind of getting more efficient with one another, that's where you start to see some sexual dysfunction creep in. And again, keep in mind, the couples who kind of realize that that is normal, don't make a big deal about it. There's not anxiety building up or shame or concern about the relationship or concern about how this person feels about the other person. If knowing it's kind of normal, it's actually a good thing for couples. Okay. So couples that get all worked up about any kind of transient dysfunction, that getting all worked up about it and getting worried about it is going to create problems. Now, remember when we talked about how we need, for the desire and the arousal stage, we need parasympathetic rest and digest to be in control. What happens in most cases of sexual dysfunction, instead of sexual activity being associated with pleasure and loving and fun and enjoyment, sex starts to get classically conditioned to anxiety or problem, feeling like there's performance pressure. And one way of thinking about this very simply is that people are going to have a better sex life if they're totally focused on the sensations in their body, and they're focused on loving and giving pleasure to their partner and receiving pleasure. So the mind's attention is actually in the physical sensations in the body. And we're going to see in a little bit of treatments called sensate focus. So if we're focused on the sensations, the whole sexual response cycle is likely to flow and go accordingly. It's going to go well. As soon as a person gets in their head and starts thinking, a common one for women is if they've got body image issues. And we know that body image issues for women tends to be associated with sexual dysfunction, because for women, if they get in their head and they're like, oh, my breasts are too big, my breasts are too small, my thighs are too big, my thighs are too small, my butt's not big, and all this kind of, if they get into their head about, oh my gosh, how do I look here? And what's he or she thinking about how I look here? You're going to get dysfunction, because then the mind is not focused on the physical sensations. Okay. Same thing for if somebody's very worried about, are they enjoying this? Am I doing it well enough? As soon as they're in their head with that performance pressure, then their body's usually not going to function. Okay. So what we're going to want to do is, for individuals where this has happened, and what we do in couples therapy is a lot of times when we do sex therapy, we meet with the couple and we discuss what's going on, what the problem is with them together. But then what we usually do is have individual meetings with both individuals in the couple, and we look to see if there is any history for that individual that could be explaining some of what's going on. So an example might be, let's say we've got a woman with sexual dysfunction and there was a sexual assault that happened to her that she has not disclosed to her current partner. Or I've worked with individuals before who had a history of an unplanned pregnancy and an abortion and felt shame about that. And that was hindering their ability to experience pleasure for maybe fear of getting pregnant again, that type of thing. So a lot of times in couples therapy, we will meet with the couple together, but then we'll meet with them separately to see if there's something going on. Another secret that sometimes people who are doing sex therapy hear about is there's an affair going on. So there's sexual dysfunction in the committed couple, but somebody's cheating, and that's part of what's going on. Or somebody's suspecting somebody's cheating. That'll put a dent in a sex life too, if there's even just a suspicion, regardless of what's going on there. Okay. There also tends to be, and keep in mind, you can see compatibility in couples. And I can tell you that sexual satisfaction, reported sexual satisfaction, is one of the best predictors of relationship satisfaction. Okay. You can have relationship satisfaction without good sexual satisfaction, but sexual satisfaction is a big predictor of relationship satisfaction. And again, we're talking about enduring relationships, not just dating or hookups here. You can have incompatibility in gay couples, and you can have incompatibility in heterosexual couples, but the incompatibility in heterosexual couples tends to fit a particular pattern. And so let me exit here. This is just for funsies. And again, we're all adults. I'm not picking on women. I'm not picking on men. But I've got here, let me share this. Let me come back over here. Okay, let me share this screen. So I've got on the computer here an orgasm simulator. And so again, this is kind of getting at what for heterosexual couples can be some slight incompatibility, which is interestingly, you see in gay couples, there tends to be sometimes incompatibility, but there's a better understanding in gay couples how my body works is how your body works. In heterosexual couples, there is a difference in that. So here, okay, we're gonna have a male orgasm here. This is just a joke. I'm not picking on guys here. All right, that's it. It happened. let's do her now. Okay, we're gonna do her. She's a little more complicated. Oh. All right, just for funsies. So a lot of times in sex therapy with couples, we need to look at what their expectations are. We review the history of their sexual relationship. And I'll give you some examples here in a minute. So Masters and Johnson, after they did a lot of their observational research with people masturbating, gay and straight individuals having sexual activity while they were all wired, they came up with their treatment program, and it's called Sensate Focus. And keep in mind that a lot of times what we're doing with couples that are having sexual dysfunction is we do want to get them to open communication. Okay, so if there's anything stuff that they've been kind of keeping secret or hiding from the other, a lot of times we need to get that communication open and talk about it. But one of the things that Sensate Focus does beyond just talking about problems in the bedroom is Sensate Focus is a behavioral program. Okay? And it is sort of based on systematic desensitization. And again, if sex has now become associated, classically and operantly conditioned, with stress, with problems in the relationship, with pain, with dysfunction, with anxiety, then it's not going to unfold well for the individual, and it's not going to unfold well for the couple. So what is done in Sensate Focus, again, we will usually meet with the couple together, meet with them separately. If there's any secrets in the separate, we've got to figure out how to handle that and how to manage that. For example, I worked with this young college couple at one point in time, and they were just struggling to be able to have successful intercourse. And she had not disclosed to him a previous sexual assault, that she had been raped. And what we needed to do in that situation was she was able to disclose to him and let him know, it's like, sweetie, I love you. It's not you. It's this really bad experience that I had, and the conditioning that happened to her own sexual response as a result of this sexual assault and all the pain that she experienced in that sexual assault. So in that situation, what you do from a therapeutic standpoint is we had to veer into individual therapy for a while with her and treat her sexual assault history. And then what you get individuals doing, particularly for women who have this history, particularly if the women have not masturbated, there are videos and there are books and things that you can purchase online that can help in masturbation training, is what it's called. And we know, I remember we talked about that tremendous variability that we see in women that we don't tend to see in men, that women who discover their own bodies and learn how to masturbate to the point of orgasm themselves are a lot more likely to be sexually responsive once a partner is brought into their lives. Okay, they're able to transfer that response and that information over to a partner. Women who have never had that experience, who have not learned about how their own body operates and have not masturbated, are a lot more likely to not reach orgasm once they are partnered. Does that make some sense? And so a lot of times when we have to kind of veer off and do some individual therapy and then get back to the couples therapy. What ends up happening in sensate focus, and I've done this with some couples, it can be fun and it can also be very challenging, is what you will first do is establish a rule of no attempts at full sexual contact, no oral sex, no intercourse, and you will put basically a time out on that kind of sexual touching for X amount of time. And at times that X amount of time is a roaming deadline. So let's say I start out with a couple and I say, okay, we're going to do the sensate focus. You all are absolutely not to have any sexual contact until we meet and we agree you can go to the next level of sexual contact together in this room. All of us agree. Okay. So that type of sexual contact is forbidden, let's say 2 months until we do the sensate focus. And what that does, you all, having that rule, like, okay, we're going to back up here and we're going to stop being sexually active for X amount of time, it takes the pressure off. Okay. So there's not the fear of you come home from work, we hug and we kiss, and then the kiss goes longer. And then what if you want to start something and then you want to go to bed and have sex? It's just cut off for X amount of time. And then what you do is you have the couple kind of go back to the sexual script and move in gradations in their homework to the point where they feel comfortable and there's no anxiety, there's only pleasure. So as an example, I might start a couple out with their homework assignment for the week is to exchange back rubs or back scratches. Okay. So it's non-sexual touching. It is pleasurable. It feels nice to get a back scratch or a back rub. It was funny when my sons were growing up, my mom had long fingernails. I've never had long fingernails. So they loved it when Nana would scratch their back. But one of my sons, when I would give him a back rub, he just really sort of digging into the muscles. And my other son, they're both weird in their own ways. My other son had this thing, he called it soft touch. He's like, don't dig, mom, do the soft touch. And the soft touch was like this tickle. I'm like, you're a weird kid. But he would just want his back tickled. And he would be like, oh, that feels so good. And then the other one's like, dig, mom, that kind of thing. So what I'm getting at, there's individual differences even in what we want in a back rub. Okay. So imagine the individual differences in what people like in sexual touching. So that assignment, that back rub, back scratch, whatever it is that, they decide they want, is also an exercise in communication. Does that make some sense? And again, my sons were pretty good at telling me or Nana what they wanted when they got their back scratched or the back rub. Okay. So let's say dude's down, lowering your back and he's squeezing, and what you really want is some soft kind of rubbing up on your neck and be like, dude, up here. So I want it up here. Okay. And what that ideally does is it opens communication to what feels pleasurable, but it's a start in opening communication on here's how I like to be touched sexually in a way that feels good for me. Okay. Then they come back, and after they've done stuff like that, where they've done hand holding, they've done back rubs that say they're allowed to kiss one another and have more of a sexual kiss, as long as there's no anxiety in either individual, then we move it to the next stage. And then there's allowed to be bodily touching, full body hugs, full body touching. And then we move ahead to foreplay. And then eventually in this, if there was any of that classically conditioned anxiety, particularly if there'd been history of assault or history of pain, we have now desensitized that the touching is pleasurable and feels safe. And there's better communication back and forth. And eventually couples either cheat on the therapist. They just go and they do it. And then they come back and say, oh, we cheated. We had intercourse. It was great, that kind of thing. Or they reach a stage where they come in like, oh, please, 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 please. We are ready. We want to go do this. Okay. But does it make some sense that it's almost a reconstruction for a lot of couples, undoing the conditioning that has occurred either in an assault or the conditioning that has occurred in that relationship over time? But it's a bit of a return to the classic sexual script also. Okay. I worked with this one couple. They were referred to me, interestingly, by their minister, because technically they had not consummated their marriage. They had not had, they wanted to, but they had not consummated their marriage. And they went to their minister asking for help, and their minister was smart enough to know that he didn't have the training in this kind of stuff, and sent the couple to me, and they were a great couple to work with. She had a history of an assault that had not been disclosed. And once we found that out, then I was able to kind of do some individual therapy with her as well as couples therapy. And they were really good at, it took her a while to go through the sexual script and feel relaxed and feel comfortable. And so I spend a lot of time with them negotiating, like, okay, here would be the next step forward. Woman, do you feel like you're ready to move forward? And she would oftentimes be like, I don't think so. I think I need more time at this stage. And then I did a lot of like telling him like how great he was for being patient. And it was just ongoing negotiation, working through the different stages of the sensate focus. But in that particular case, there was a point in time where, because again, they were kind of newly married, had not consummated their marriage, that even though we were going through the sensate focus and we were all kind of on the same page, he got to a point where he got extremely worried. It took him a while to kind of disclose this. He got really worried that she was regretting marrying him. And that, he's like, I think maybe she doesn't love me. Maybe she didn't want to get married. And he got that in his head. And then he started having some sexual dysfunction issues because he had lost some of that sense of trust and commitment and that type of thing. So a lot of negotiation went on and does go on in these kinds of treatment. It is, again, this isn't just talking. It's actually the whole behavioral therapy in sensate focus. And it is much more effective than just talk therapy for couples. Okay. All right, here's my joke. Somebody's in trouble. Somebody has cheated. Okay. Okay. I'm going to go back to the view for everybody. That's it for slides today. What comments or questions do you all have? Anybody with this stuff? It's fun to do sensate focus and to be successful, to help couples get back, either get back or get for the first time, like that young couple that I saw, to be able to reach that place where they are able to love one another and have really good sexual activity with one another. That's kind of a fun thing to do as a therapist, to help people out in that way. All right, any other thoughts or questions, buddy? Okay, so on Thursday, we will pick up and we will do the sleep disorders. Okay. All right, good to see everybody. Y'all take care. Bye.